There's two really, I'd say at least two really important things that I like to do before I do any eye movement training or adjusting. And the very first one is to check for balance. And I like to use this pad. It's called an Arex pad. These are high quality. I would strongly recommend that you don't go cheap on these because it does make a really good difference. When patients come in, I throw this on the floor all the time and have them stand on it. Even regular chiropractic patient, I just want to see what kind of sway pattern they have, and that will guide me in what I need to do to prepare them to receive an adjustment or to start doing eye movement training. And the reason why is because if there's some kind of vestibular problem, that's really what I'm checking for. If there's some kind of vestibular imbalance, we can see that in eye movements, we can see that in balance. And we want to correct that before we do an adjustment and before we do eye movement training, because neither one of them are going to be as good as they can be with that kind of interference. The vestibular system is very powerful. It moves the eyes, it shifts muscle tone, it creates imbalances and postural tone. It makes changes in your posture. It makes it a lot harder to stand straighter when you have these imbalances. We want to fix all that before we do either one. I think it just makes good sense. And so I'm going to check Skylar's balance here. I'll go ahead and stand on the pad facing this way. And you could do quick, I start off with eyes open here. You can do just a quick check how they're doing with eyes open. Are they able to stand on there? Is there somewhat of a noticeable sway? But it's really with the eyes closed that you get the most information about the vestibular system. And he's doing pretty good here. I like to put my hands up like this because when I do that, it gives me some kind of reference point. I can see, is he moving closer to that hand or this hand or both hands or away? And that's really what I'm looking for. So go ahead and Skylar, close your eyes and hold still. Just try to maintain good balance. And what I'm noticing here is he went front left and then he came back towards this hand, and then there's all sorts of other compensations that happen after that. You can open your eyes now. Okay, so he went front left, then back right. And those are minimal shifts, and that's good. They're very, very important. It doesn't have to be huge. Now, when you see a shift that goes forward left and back right, automatically you think there's something going on with the posterior canal on the right side or the anterior canal on the left side. They're paired together, and this is exactly how they work. So we have got, if I can get these straight here, there we go. We've got a canal system. We have 3 canals on the one side, 3 canals on the other side. Okay, these are the receptors that tell your brain about angular movement of your head. And so if he's moving forward left, you can see that left anterior canal right here is being activated. When he moves back right, that right posterior canal is being activated. They're paired together. And that's, if you're not sure where he moved initially, that's okay. Just look at the pattern. Is it front left, right back? Or is it front right, back left? Or is it to the right? Or is it to the left? Or is it some kind of rotating pattern? Those are the big ones. And sometimes it's going to be just straight forward, straight back. Most of the time you're going to see an ellipse that goes front to one side, back to the other. That's the most common one. And so let's just kind of work through what we found here initially. He went forward left first and then backward right. If he goes forward left, especially in a healthy young individual like him, my thought is most likely that right posterior canal right here, this one, it's too active. If it's overactive, if its perception of motion is greater than normal, it's just not calibrated properly, then as soon as he closes his eyes, the brain's going to feel, oh, I'm moving back and to the right. So he's going to pitch forward and left as a compensation, okay? And then he's going to come back into that posterior right position as a response. Now, what happens posturally here is that if the brain is feeling like you're falling back into the right, posturally, there has to be a forward left shift or compensation. But the muscle tension will be in response to the postural compensation. So you're going to see tightness on the back side of the neck and the trap, possibly the hamstring and the calf on that side, maybe the lower back or the glute. So that posterior chain on the right side. And sometimes it's just the neck, sometimes it's just the trap, sometimes it's just the lower back. Sometimes it's just one of those areas. And what I think is the reason for that, because you would think, the calf would be maybe one of the first places you would see it, maybe the neck too, the neck and the calf muscle. But sometimes it's just the lower back. And I think what happens, wherever is the greatest level of stress mechanically, that's the area that will light up and symptomatically will feel worse first. So what I do in situations like this is I do an Epley maneuver, and I'm going to show that to you in a minute, and I do a times 0 times 1 strategy with the head and the eyes to affect the central component of not just the peripheral issue, but the central aspect as well. I just do them both. Now, let's just say, first of all, if before we do that, let's just say that he went backwards, okay? I saw that just a couple days ago in my office, and the patient just, eyes open, they're just falling back, and I have to catch them. So in that case, they just go straight back. There's no compensation, nothing. This was a recent concussion situation, and most likely in that case, we've got some aspect of central integration that's disrupted, and that certainly is not responding fast enough, right, or at all. And so this would be more of a depressed or hypo-functioning posterior canal system. Okay, I'm not being specific exactly where that is. There's some possibilities there. Certainly that junction between the cervical cord and the medulla is one common area, or midline cerebellum. And in those cases, you'll see some downbeat nystagmus. And if you see downbeat nystagmus, you want to really think about maybe double checking to balance if you're seeing that it matches. But the downbeat nystagmus, you can see it very easily on the right eye testing. So if you use the right eye system, on the horizontal pursuits, you'll see these downbeats. And I see those a lot, especially in people who've had TBIs. Anyway, in that case, we want to do something different to strengthen and habituate that posterior system. And I'll show you a few things with that after. But we need to know which direction they're going. Now, let's say, for example, that he was moving in a circle like this to the right. My suspicion would be, there could be a right cerebellum deficiency or weakness. There could be a right horizontal canal that's under-responsive, underactive. Those are possibilities. You want to compare to other exam findings. But another possibility too is you could have just a direct side shift. So if he's shifting to the side like this, then you're thinking vestibular complex, cerebellum on the right side, most likely weak. Of course, there's other possibilities, but if I'm seeing a patient real quick that's pretty healthy, that's what I'm thinking initially, okay? So now what if the patient just goes straight back and then they compensate and go forward? Well, if they go straight back and forward, their compensation mechanism is working. I think a lot of times you're going to see just a very small forward movement, if you even see it, and then they're going to go back and then compensate. So naturally, if they're going straight back, it's much worse. You don't let those patients leave until you've addressed the issue. That's a dangerous place to be when you can't catch yourself or respond to a posterior fall. If it's just a slight drift and back, then it could be that both posterior canals are involved, and in that case, we want to do something to really kind of habituate that. It could be that the vestibular function overall is down, and that's typically what we'll see. It could be a frontal mechanism that's deficient as well. What I like to do, if we get this posterior shift here, Skylar, I'm going to have you stand facing the wall over here. If it's even, both sides are just go straight back and forward, I'm going to have them walk down the hall backwards. And, a backward walk is a controlled fall backwards. Okay, so we want to get the system used to controlling a backward fall and really gaining that control back. And so I'm going to have Skylar walk back and just he's going to take 2 steps. When you step back, bring your arm up on the same side that you step back, okay? So just go ahead and do that 2 steps and then turn around and come back. There's one, and there's two. So turn around and do the same thing coming back. There's one, and there's two. Okay, now normally I would have a patient do that in a hallway and do a little bit more. I usually do somewhere around a minute of it. These are mostly healthy individuals. These are my chiropractic patients who come in and we do a quick check. We see that, I have them walk back and I recheck them right away. And if that sway pattern is better, and it typically is over 90% of the time, the patient is impressed before they even receive an adjustment. You'll see their posture change and improve right away. And then hopefully your adjustment will facilitate more of a change. Okay, so now that they've did this backward walking, they're in a better position to receive their adjustment. Now let's just say that he was going back and to the right. This is what we saw earlier. The first thing I'm going to do is an Epley maneuver, and that Epley maneuver is going to be for the right posterior canal. So we're going to do that right now, and then I'm going to show you what we do right after the Epley to fix this. So let's go to the table over here, and just so you can see, this is the posterior canal, okay? You can see how slow, I don't know if you can see it clearly there, but how slow the movement of the otoconio is within the canal. It takes a long time to make its way all the way down. It's very slow. And so this has to be done carefully, and you can't do this maneuver quickly. There's just no way around it. So hold it each position at least 30 seconds. I like to go up to a minute typically, but if you don't have that kind of time, do 30 seconds in each position, and that makes a good difference. So here we've got the canal. He's going to turn his head to the right, and he's going to go down so that the canal is in its favorable plane. So there we go. Eyes are closed during this movement. And now that his head is in position, this posterior canal is in plane like this, straight down. And we're allowing for all these otoconias here to work their way down. And I typically wait about 30 seconds, like I said. And once they made their way all the way down at the bottom of the canal like this, then I'm ready to go to position number 2, okay? Now he may not even have BPPV. You know, we're doing this because we're finding that there's tremendous benefit in doing this even without this going on. But we still do it as if he had it, and that's how you get the most benefit from this. So okay, so you reach the bottom here. Now we're going to go into the next position, and eyes closed during the movement. They can open their eyes in between if they want to, but when you move the head, you want the eyes to be closed. So I'm going to slowly, very slowly move the head into position 2. So we went from 45 degrees to the right on the side of the overactive canal to 45 degrees to the left. And now what we've done, get my model here, is we shifted the head the other way, and now the otoconio is starting to work its way down just a little bit further. And after 30 seconds, I'm going to have him turn on his left side. So go ahead and turn on your left. And I keep his head real still. I've got my hands on his head. I don't want that head to bob around all over. So, and now that we're in position, I'm going to slowly turn the head so that he can face down towards the floor, tuck in his chin, and just hold that position here. If you're thinking that, wow, this would really lengthen my visit, you know, I see my chiropractic patients, I say chiropractic, the ones that are here for spine care only, in 15-minute time slots. I can get this done within that time pretty easily. So again, it's 30 seconds in 4 positions. That's 2 minutes. It takes you 2 minutes to do this maneuver. Maybe add another 30 seconds for the eye head strategy. And you may not have to do this every time. It gets better very quickly, and you get to a point where it clears up sometimes after the first visit. Sometimes it takes a few visits of doing it. But the patients, I can tell you, Skylar's worked with me here in the office many times, and you just cannot compare the outcome to just skipping this part. It's so good that not only is the patient going to value what you do and recognize that you have their best interests at heart, and you'll do everything you can to make them better and keep them better, But they feel different. It feels great to have this maneuver done. It takes all that tension down. And a lot of times, some of the things I may have adjusted, I've seen what appeared to be like neck subluxations, I didn't even have to address because we took care of this. So Skylar, I'm going to have you sit. And as you sit, keep your head exactly in the position that it is. You'll bring your legs in front of you. Make sure you keep looking down. Keep your head real still. And stay in that position. So now, what we've done is we went all the way around, and now we're in this position, the anterior canal position here. And you'll see that the otoconio is just traveling, making his way all the way down to the end. So it went all the way around the canal. Okay? So he's going to hold that position there, and I'm going to make sure that he doesn't get out of position until I've done my times 0 times 1 strategy. So after 30 seconds to a minute, I'm going to ask Skylar to open his eyes and look at my thumb here. And you're going to follow my thumb with your head and your eyes all the way back and to the right. So we're going into that overactive canal position. Okay? And I often will hold the patient's head just to make sure they don't get out of position. Now keep looking at my thumb, and you're going to move your head side to side in a no-no position. Do that 10 times. So this is just small amplitude no-no motion. This kind of breaks that vertical plane, that unstable plane, by activating that horizontal movement. Now with eyes only, so keep your head there. Follow my thumb with your eyes only. Good. Keep looking at my thumb and bring your head down to neutral. Now the eyes are looking up and to the left. This is the left anterior canal position. We're activating it. The left anterior canal inhibits the right posterior canal. And now I'm going to have him do a yes motion down and center. So he's going down and return to center 10 times. And again, this is further inhibiting that right posterior canal. The vestibular ocular reflex is what we're inhibiting here. So this is bringing about a tremendous amount of balance within that system between the anterior and the posterior canal. Good. All right, this is the end of our maneuver. So right after that, I would probably encourage him to go walk backwards for a little bit, recheck his balance, and then adjust. So if he had a movement to the right, let's say it was an overactive, let's just say that we had an underactive right horizontal canal. We could do a barbecue roll where we might inhibit the left side. You just want to make sure that that's exactly what you're having. A lot of times what we find too is that you'll move into the overactive side because there's an initial movement in the opposite side and there's a compensation, and you're going to see the greatest amount of movement into that overactive one. And that's why a lot of times you'll see a lot of posterior movement. And I do the maneuver into that posterior, that excessive movement position. So again, with the horizontal canals, it could also go either way. I tend to start, especially with healthy individuals, I'll tend to move the head or do a maneuver into the canal that has the greatest amount of movement. Because typically you have a small compensation initially and then a bigger shift. So if it were a right canal, horizontal canal, what I would do is tilt the headpiece up about 30 degrees and go ahead and put your legs straight up this way. Okay, and I would have him turn his head to the right, close your eyes, and lie down on your back. This is position 1. He would stay in this position for 30 seconds, and then I would slowly bring the head to neutral. This is for an overactive right horizontal canal. And then we're going to keep it in neutral here for 30 seconds. And then we're going to go to the left. I'm going to go to the left here for 30 seconds. And then he's going to turn on his left side. Again, I'm stabilizing the head, making sure it's nice and still. And then after 30 seconds, we're going to go down, face down. So go ahead and lay down on your stomach. 30 seconds here. And then we're going to go back around another 30 seconds. So turn on your right side. So, and when I'm done, I'm either going to have him sit up from there or just turn on his back, depending on what I want to do next. I'm just going to choose to have him sit up. And he would end up being on this side. I'm just going to have him turn around the other way so that you guys can see. So with an overactive right horizontal canal, the central, the times 0 times 1 strategy would be follow with your head to the right, and then keep looking at my thumb as you bring your head back to center. Okay, then close your eyes, open your eyes again, follow to the right, keep looking at my thumb, come back to center, close your eyes. I would do this at least 3 times, and then back to center and close your eyes. Okay? Now, a lot of times you'll see, especially if you see tightness on one side of the neck, let's say if it were the right side, this little strategy can help to bring that tension down pretty rapidly, especially if there's a vestibular cause. Naturally, if he's subluxated and that's what's causing it, you might have to do the adjustment to resolve that. Now, this is addressing the majority of what you're going to find. And so it's very rare that I even have to do other kinds of strategies. Now, again, if they're falling back, you got to do more investigating because there's a lot more happening there. The injury level is a little bit higher, and the backward walking may work very well for that person. It works well for the majority of the ones I see, and there's some exceptions too that don't fit the criteria.